Welcome to the deep dive. Today we're getting into a really important topic, especially if you're revising or just want to understand it better. Primary hyperparathyroidism, PHPT.
Yep, PHPT.
We've got some focused revision notes here, and basically our mission is to break this down so it really sticks.
Exactly.
We'll cover everything: definition, causes, complications, the whole lot. We'll try and use some memory aids too.
Sounds good. Think of it like a high-yield guide. We're taking those keynotes and digging in to make it, really clear.
Great. So let's start right at the beginning. What exactly is primary hyperparathyroidism?
Okay, so at its core, PHPT means one or more of your parathyroid glands are just, well, overactive. They're producing too much parathyroid hormone, PTH.
Too much PTH, and that causes problems.
Right. This excess PTH messes with your body's calcium and phosphate balance. You end up with high calcium in the blood, hypercalcaemia, and other sort of metabolic disturbances.
And these parathyroid glands, remind us where they are again.
Yeah, they're usually tiny, like 4 of them, tucked away right behind the thyroid gland in your neck.
So near the thyroid, but different job.
Completely different function, yeah. The parathyroids are all about regulating calcium. They release PTH, which controls calcium, phosphate, and bone metabolism, basically. It's like the body's thermostat for calcium.
Okay. So in primary hyperparathyroidism, the problem starts right there, in the glands themselves. Are there other kinds?
Absolutely. You've got secondary hyperparathyroidism. That's more like the glands reacting to low calcium caused by something else, maybe kidney problems, liver issues, bowel disease, that kind of thing.
Right, a response.
Exactly. And then there's tertiary hyperparathyroidism. That's where the PTH production just keeps going on its own, often after long-term kidney disease. But for this deep dive, yeah, we're focused squarely on primary. The glands themselves are the source of the problem.
Got it. Primary it is. So what actually causes the glands to go rogue like this in PHPT? What's the etiology?
Well, the most common reason by far is a single non-cancerous tumor, an adenoma. That accounts for something like 80% of cases.
80%. Just one little growth causing all that trouble.
Yeah, basically one gland just gets stuck in the on position, pumping out PTH.
Interesting. What about the other 20%?
Okay, so in about 15% of cases, it's hyperplasia. That's where all 4 glands are enlarged and overactive. Less common, maybe around 4%. You might see multiple adenomas.
Multiple growths.
Right. And very rarely, thankfully less than 1% of the time, it could be actual parathyroid cancer, a carcinoma.
Okay. And are there things that are linked to this, factors that make it more likely?
There are a few associations, yeah. Sometimes seen in people with high blood pressure. It can also be part of inherited syndromes, like multiple endocrine neoplasia, MNN type IN2.
MNN syndromes, right?
Yeah, and sometimes it just runs in families. There are specific genetic things involved in rarer syndromes, too, like hyperparathyroid jaw tumor syndrome, HPTJT, and another one called familial isolated hyperparathyroidism, or FIHPT.
So genetics can definitely play a part.
For sure. We don't always know exactly why the adenoma or hyperplasia develops, but the family links and maybe some suggestion about past radiation exposure,
Yeah.
it hints at predispositions.
Okay, so that covers the causes. Who is actually most likely to get PHPT? What are the key risk factors we should know?
Well, the notes highlight a few main things. Age is definitely one. It's much more common in people over 50.
Over 50.
Yeah. And also being female, women are about 2 to 3 times more likely to develop PHPT compared to men.
Wow, 2 to 3 times. That's quite a difference. Any idea why?
That's a really good question. The notes don't spell out a definitive reason, but, hormonal factors are often considered when you see these kinds of gender differences in conditions. It's complex.
Makes sense. What else?
Well, like we mentioned with the causes, those genetic disorders like MEN1 or just having a family history of PHPT increases your risk.
Right, the family link again.
Exactly. And one other thing, current or past treatment with lithium, that medication used for some mental health conditions, that's also flagged as a potential risk factor.
Lithium, okay. Good to know. So we know what it is. Who gets it? Let's dive into the pathophysiology, what's actually happening inside the body.
Right. So in PHPT, those abnormal parathyroid glands, whether it's the adenoma or the hyperplasia, they basically stop listening to the body's signals. They lose sensitivity to the normal calcium feedback loop.
So they just keep churning out PTH no matter what.
Pretty much. They just keep pumping out PTH even when calcium levels in the blood are already high.
And what does all that extra PTH do?
Well, PTH acts in a few key ways. First, it tells your bones to release more calcium into the blood, like raiding the calcium bank.
Calcium from bones.
Second, it tells the kidneys to hang on to more calcium reabsorb it from the urine so you don't pee as much out.
Holding on to calcium.
Third, it also tells the kidneys to get rid of more phosphate, so you get this calcium-phosphate imbalance.
High calcium, low phosphate, potentially.
Often, yes. And there's one more crucial bit. PTH also stimulates the kidneys to produce the active form of vitamin D calcitriol.
Ah, vitamin D.
Yes, and that active vitamin D then boosts how much calcium you absorb from your food in your intestines. So you've got multiple things all pushing blood calcium levels up.
Wow, it's like a perfect storm for high calcium. Okay, so if someone comes in with high calcium, how do we know for sure it's PHPT and not something else? What are the differentials?
That's a really key question. One major thing to rule out is something called familial benign hypercalciemia, FBHH.
FBHA.
Yeah. With FBHH, you also get high calcium, but the PTH level might be normal or only a little bit elevated. It's inherited, autosomal dominant. Basically, a gene defect means the parathyroid gland's calcium sensors aren't working right. They think calcium is lower than it is.
And the really crucial difference.
The crucial thing is that surgery on the parathyroid glands doesn't work for FBHH. It won't fix it. That's why distinguishing it is so important.
Vital distinction. What else looks like PHPT?
Well, lithium treatment can cause high calcium, as we mentioned. So lithium-induced hypercalcemia, tertiary hyperparathyroidism, often linked to chronic kidney disease, can also present similarly, but the underlying history is different.
Right, the kidney disease context.
Exactly. And then you have to think about other general causes of high calcium, certain cancers, hyperthyroidism, sarcoidosis, Paget's disease of bone, even Addison's disease. It needs careful investigation.
Okay, so it's definitely not always straightforward. How common is PHPT then? Let's talk epidemiology.
The figures vary a bit, but here in the UK, the prevalence is estimated around 1 in 800 people.
1 in 800, so not super rare.
Not at all. Globally, it's often cited as the third most common endocrine disorder. Affects maybe 1 to 4 people per 1,000.
And that female prevalence holds up in the bigger picture.
Oh yeah, definitely.
Yeah.
Consistently about twice as common in women as in men. And in the UK, women are typically diagnosed often between 50 and 60 years old.
And 50s, peak time.
Seems to be. And it's interesting, the incidence rates can vary depending on geography and race, too. Like in the U.S., estimates are maybe 66 per 100,000 person years for women, but lower for men, maybe 13 to 36 for 100,000.
Right. So we're likely to see this, especially in women over 50. How does it actually show up? What are the typical signs and symptoms, the clinical features?
It's really quite variable. Some people have 0 symptoms. It just gets picked up on a routine blood test showing high calcium.
An accidental finding.
Exactly.
Yeah.
But others definitely feel it. Common things are fatigue, just feeling wiped out, muscle weakness, bone pain, maybe even fractures. Kidney stones, renal calculi are pretty common too.
Okay.
Yeah.
Yeah.
And then gastrointestinal stuff like constipation, nausea, and psychiatric symptoms can happen too. Anxiety, depression, memory problems, brain fog.
That's a real mix of symptoms.
It really is. And in really severe cases, if the calcium shoots up very high very quickly,
Right.
you can get what's called a hypercalcemic crisis.
That sounds serious.
It is. That involves things like profound muscle weakness, maybe anorexia, vomiting, bad abdominal pain, dehydration. It can even lead to coma in extreme situations.
Okay, definitely serious. Is there an easy way to remember the common symptoms?
Yes. There's the classic mnemonic, you've probably heard it, bones, stones, abdominal groans, and psychic moans.
Ah, yes, the classic. Bones, stones, groans, moans.
Exactly. Bones for the bone pain, fractures, stones for kidney stones, abdominal groans for the GI symptoms, and psychic moans for those neuropsychiatric issues like anxiety, depression, confusion.
That's super helpful.
It is. So yeah, while it might be picked up incidentally, you might also see patients presenting with just vague stuff like fatigue, muscle aches, anxiety, memory loss, maybe alongside a family history or other clues.
Right. So if we suspect PHPT based on symptoms or that high calcium blood test, what investigations do we do next?
Okay, first step is always confirm that serum calcium. If it's high, suggestive. If it's kind of high normal, especially if you're suspicious, you'd want to recheck it, maybe after fasting.
Recheck, okay. And the key test for PHPT itself?
That's the serum intact PTH level. In classic PHPT, you'll see high PTH alongside that high calcium, usually measured with specific assays, immunoradiometric or immunochemical ones.
High calcium, high PTH, that's the hallmark. But what about FBHH, where PTH might not be super high? How do we sort that out?
Right, good point. That's where the 24-hour urinary calcium test comes in really handy.
Urine test.
Yeah. In PHPT, urine calcium is usually normal or even high. But in FBHH, it's characteristically low, hence the hypocalciuric part of the name. That helps differentiate.
Ah, low urine calcium in FDHH. Okay, crucial distinction. Any other blood test?
Definitely check the 25-hydroxy vitamin D level. Vitamin D deficiency is common, and it can sometimes push PTH levels up a bit artificially, so you need to know if that's going on and correct it.
Address the vitamin D. Got it.
Yeah, and sometimes serum alkaline phosphatase is checked. If that's high, with normal liver tests, it might point towards higher bone turnover, which could mean a slightly higher risk of low calcium after surgery.
Okay, and assessing the bones directly.
Once you've confirmed PHPT, a DXA scan, dual energy X-ray absorptiometry, is standard. Measures bone density in the spine, hip, and forearm usually.
DXA scan for bone density. And do we need imaging to find the naughty gland?
Not always needed for diagnosis, but often done before surgery. Things like a neck ultrasound or a special nuclear medicine scan called a sestamibi scan can help localize the abnormal parathyroid gland or glands, makes surgery potentially easier.
Helps the surgeons. Makes sense. So it's a combination of bloods, urine tests, maybe bone scans, and imaging to really nail the diagnosis and plan things.
Exactly. Repeating tests is sometimes needed. You look at the whole picture, symptoms, history, the numbers. The goal is confirm it, see how much it's affecting the patient, and then figure out the best management plan. And yeah, don't forget checking and maybe treating that vitamin D deficiency.
Right. So we've got the diagnosis, PHPT. What happens next? What are the management options?
Okay, so the main treatment options fall into a few categories. Surgery is often the definitive fix of total parathyroidectomy, removing the overactive gland or glands.
Surgery first, usually.
Often, yes. But there's also conservative management. That's basically watchful waiting, close monitoring. It's an option for some people with very mild hypercalcemia who meet specific criteria like normal kidney function, good bone density.
So not everyone needs surgery immediately.
Not necessarily. Then there are medications. Cinacalcet is a calcimetic drug. It basically tricks the parathyroid glands into thinking calcium levels are higher, so they release less PTH. It's mainly for people who can't have surgery or choose not to.
Cinacalcet, okay.
We also, as mentioned, give vitamin D supplements if needed. And if there's osteoporosis, bisphosphonates might be used to help strengthen bones.
So when is surgery definitely the way to go?
Surgery is generally recommended if the patient has symptoms, the bones, stones, groans, bone stuff. Also, if there's clear evidence of bone disease on DXA scan or kidney stones, or significant neuromuscular problems. And even for asymptomatic patients, if they meet certain criteria based on age, calcium level, kidney function, or bone density.
Right, specific criteria even without symptoms, and the medical options like cinacalcet.
Cinacalcet is mainly for those not having surgery, either because they're not suitable or they decline, especially if their calcium levels are quite high. Bisphosphonates might be considered to reduce fracture risk, particularly if surgery isn't happening soon, but it's all about tailoring it, monitoring, and adjusting as needed.
Makes sense. So if someone gets the right treatment, what's the long-term outlook, the prognosis?
Generally, it's really good with appropriate management. Surgery is usually curative for PHPT. Symptoms often resolve, calcium levels normalize.
That's great news.
It is. But, if someone's had very high calcium for a very long time and complications have already developed, that can, of course, affect the long-term picture.
Right. Which brings us to complications. What can go wrong if PHPT isn't treated or managed effectively?
Well, several things. We've touched on them. Osteoporosis, increased fracture risk, kidney stones leading potentially to chronic kidney disease. There's also suggested links to cardiovascular disease. Those neuropsychiatric issues can persist. And, of course, that severe hypercalcemic crisis in acute situations.
Okay. And what about complications from the surgery itself?
Yeah, like any operation, there are risks. One specific one is hypocalcemia, afterwards low calcium, sometimes called hungry bone syndrome because the bones suddenly start soaking up calcium once the high PTH drive is gone.
Hungry bone syndrome.
Yeah. There's also a small risk of injury to the recurrent laryngeal nerve, which sits near the thyroid and parathyroids. That can cause hoarseness and, like any neck surgery, a risk of bleeding or hematoma formation.
Okay. Risks to be aware of. But assuming surgery goes well, what are the upsides? The positive outcomes?
Oh, definitely positive outcomes. You generally see improvement in bone density over time, a reduced risk of future fractures, and fewer kidney stones if the person was prone to them.
Fewer stones, better bones.
Exactly. And while it's not always a guarantee for everyone, many patients report improvement in those neurocognitive symptoms. Less fatigue, better concentration, improved mood. Though the evidence on that is sometimes debated, many patients feel better.
So overall, successful treatment can significantly improve quality of life.
Absolutely. Tackling that root cause, the high PTH and calcium, can make a really big difference across the board.
Well, that's been incredibly comprehensive. We've gone from the definition and causes of primary hyperparathyroidism right through investigations, management, prognosis, complications, the lot. Thanks so much for clarifying all that.
My pleasure. It's definitely a condition worth understanding well, given how it can present.
And for everyone listening, we really hope this deep dive has been useful, giving you that clear, high-yield summary based on these revision notes.
Yeah, hopefully covering the key points and maybe that bones, stones, abdominal groans, and psychic moans mnemonic will stick with you.
Definitely. So just as a final thought, considering how varied the presentation of PHPT can be, from no symptoms at all to quite severe issues, what do you think are the biggest challenges in catching it early? And maybe how could awareness be improved? Something to think about.
That's a really important point. Early diagnosis can make a big difference, so thinking about awareness is key.
Absolutely. And if you are revising and looking for more resources, don't forget to check out pastthemsra.com and also freemsra.com. Lots of great material there.
Definitely worth a look.
Thanks again for joining us for this deep dive.